Thank you.
Mute.
Rohit.
Hi, Steve. I'm muted or not? Can you hear me, Steve?
Hi. Can you hear you? Britta's here next door. Yeah, she's just getting set up. Yeah, I think we can maybe start quite soon. Britta, can you hear us?
I can hear you. I
Okay, good.
just don't know how to share my slideshow. I'm looking for an option.
There's a little green button called share. I'll come and check.
Oh, there. No, sorry, I'm used to Teams. Okay. Share PowerPoint. I think. Is it there? I don't know. Can you see it on your side, Pete?
Yes, I can see breast cancer screening.
Okay,
there we
cool.
go.
All right, then we all systems go.
Well,
Then we
ladies and
have one
gentlemen,
on panel.
great big thank you to Britta Dedekind, our breast and thyroid surgeon at the Christian Barnard Memorial Hospital. It's wonderful to have you here this afternoon with us, and I'd like to thank you very much indeed. And I'd like to thank Merck for sponsoring this session. It's a great resource we have, a person of your caliber, Britta, and we look greatly forward to hearing what you're going to say tonight about breast cancer screening. Our host is Professor Steve Jeffrey, who, as I've always said, and I say it unashamedly, I rate as one of the 10 best 10 best urogynecologists in Cape Town. I almost said 10 best thyroid surgeons in Cape Town.
Thyroid.
You do thyroid?
I can try.
So just before I forget, I think it's important for us to congratulate Steve and his wife for the birth of their new child. It's wonderful to have an addition to the family. And Steve, congratulations on behalf of all of us here.
Thank you.
Would you like to start the procedure this evening?
Yeah,
Steve?
so yeah, absolutely. So I'd like to thank Britta for joining us tonight. This is a very important topic. It's something that we remains somewhat controversial in terms of a number of issues that we find with it. So we really do appreciate Britta joining us to give us an update and the latest ideas about the breast cancer screening. We know breast cancer is extremely common, and yeah, so we're really looking forward to tonight. We've got a great turnout already, Britta. So, and thanks so much, and thanks for, we really see your slides are being shared already. Britta's our resident breast surgeon and really great colleague, and also very available to us as gynecologists to assist us when we get into trouble. So thanks so much for that as well, Britta. But yeah, you can fire away, and yeah, hope you don't mind if we interrupt you with questions as we go along.
Not a problem at all. I think it's much better being interactive as opposed to keeping silent until the end.
Thank you.
Cool. So I've tried to spice this up a little. It's a topic that I get asked about frequently, and I hope to share some new information with you guys that you may not have heard before. Okay.
And it's Breast Cancer Awareness Day tomorrow, is it not, Britta?
Oh, at our hospital, yeah. So it's Breast Cancer Awareness Month, October. So I started today with a presentation for the hospital, which was just a little update on the breast interest group of Southern Africa. And tomorrow we have a open session in the boardroom on the 12th floor between 12 and 2. Yeah, unfortunately that won't be available online too, but anyone who is interested is welcome to join us. Cool. So basically, and I just need to, can I reduce this thumbprint? No, I want to see my own slides. Okay, now I can see my slides. So first of all, what is the starting age for screening? And I get asked this quite frequently. So we would say that majority of women in private practice, we would start our screening in their 40s. And this recommendation is pretty standard throughout the world. But as I go along, you'll see there are slightly different recommendations depending on which guideline you're looking at and which zones you're looking at. So in South Africa, we get to kind of choose what we want to do, but we generally do a hybrid of what the Americans do versus what the Europeans and the UK do. And just to let you know that the reduction in deaths, if we screen women beginning in their 40s, will be about a 15% reduction, whereas if we only starting at 50, it's going to be about a 22% reduction. And this was a topic that I discussed last year related to why the UK hasn't extended their age range. Okay, so we've got the American College of Radiology, which is recommending age of 40 for average risk breast cancer. So that's the important thing to always put in the back of your mind. What is this patient's risk? So we should risk stratify our patients, but for an average risk patient, 40 is fine. And then our European Society of Breast Imaging, USOBI, recommends screening in average risk patients from 50 through to 69. And that then is extended up to 73 or 75. Or we have the other age group where we would do it more frequently, from the 40 to 49, where it would be annually. So it's alternate years in the 50 plus group, as opposed to the 40 through to 49 being annually. So where does this change? So specifically in known or suspected disease-causing variants. So this is where our genetics come into play. And here the most commonly known would be the BRCA gene mutation. So you have your BRCA1 and your BRCA2. But there are other gene mutations that we would also begin our screening at an earlier age. And here, both the American Cancer Society as well as the European Society of Mastology start a MRI in the BRCA1 carriers as early as 25 years of age, and in the BRCA2 carriers from 30 years of age. And those ages vary because like your total risk is obviously different depending on whether you're a BRCA1 or a BRCA2, and that risk is exponential over time. And then we have another unique risk category, which is women with a history of radiation to the chest wall before the age of 30, and they should begin their screening as young as 25 or at 8 years after the treatment had begun. Okay. Oops. So then we have the category which is quite broad. Women with a family history of breast cancer. So I frequently get calls about patients who have a family history of breast cancer and what should we do about this patient. So thankfully, we have some excellent risk stratification models available to us now. And the one that we would use most commonly is the IBIS, or as here it's called the Tyrer-Cuzick model. And that is considered the most accurate. And what's important is that it also includes breast density as a risk factor. So when we're using these risk stratification models, we would say that any woman who has a lifetime risk of breast cancer, which is more than 20% or equal to, should be having an annual MRI in addition to mammography, which sounds extreme, but this is the recommendation, and whether we're going to get buy-in from our medical aides is a completely different story. So what is the IBIS risk calculator? So it was a software tool that was developed, and you can see here it has multiple variants that you input into the calculator. So you can just download this. You don't need to purchase it. It's available freely on the internet, and what you would input into the IBIS risk calculator is the patient's current age of menarche, height and weight, so that we are accurately assessing their BMI, which also plays a role in risk stratification, parity, age of first childbirth, age at menopause, so we're trying to establish the estrogen window, then HRT use, and that's so that we can establish any additional exogenous estrogen, and then any pathology results previously. So just having had a previous biopsy, even if the result was benign, puts you at an increased risk of breast cancer in the future. And then family history of ovarian cancer, and as well as breast cancer, and then there's the various relatives that you would input, and according to whether they were male or female obviously being even more relevant, a male being even more relevant than female because of the association of the potential hereditary pathway. And then breast density is also included in this, and I tonight have focused a lot on breast density. I think it's something that we don't speak about enough and has become a huge focus in mammographic screening in recent years. And that came about with the FDA last year in America changing recommendations of what needed to be done. Okay, so moving on from the IBIS, it's another nice risk calculator that you could use, the BCSC. I hadn't heard of this before. I was doing research for this presentation, but it's a similar category of inputting agents that you put in, and then also including in that breast density. And breast density is really an important aspect that we need to include in our risk stratification, and I will come to that later. So here we have the NCCN guidelines for breast cancer screening. So you can easily find that on their website. Just wanted to jump into the actual flow diagram. So if you have time and inclination, you could read the whole article, but I think it's always nice to just look at a flow diagram to break it down. But even this is more intense than you would need to know for general intents and purposes. And it's always helpful to have someone that you can ask. And I mean, I make myself readily available to our gynecologists whenever there's something on imaging that they're not sure what the radiologist means. And I think our radiologists should also be fully aware of these guidelines. So starting on the left, we've got our clinical encounter, including risk assessment. And then you're going into the asymptomatic versus symptomatic. So we're not talking about symptomatic today at all. We're talking asymptomatic, because if it's symptomatic, we're not screening. So we've got our average risk, and there you can see they've divided into those below the age of 40 and those above the age of 40. And you can see already, even if you haven't started screening, there will be a clinical encounter as well as breast awareness is the recommendation. And then once we reach 40, there would be a clinical encounter again, and then they've got the annual screening mammography with tomosynthesis, breast awareness, and then they say they consider supplemental screening for those with heterogeneous or extremely dense breasts. So in this guideline, they are talking about the dense breasts already in our average risk patient. And the reason for that is because those patients are at an increased risk. So you need to establish that early. And then if we look at a slightly lower down, we've got the increased risk categories. So there we have those with the greater than 20% lifetime risk, which we would have established by the model that I spoke of earlier, the thoracic radiation, and then there's the atypical ductal hyperplasia and lobular neoplasia, which don't think you guys need to know about, but it's important to know that although these are not pre-malignant lesions, they have an increased risk of breast cancer in the future. So not something to just brush aside if a patient's biopsy does come back as atypical ductal hyperplasia or lobular neoplasia. And then we've got the last where they are talking about patients who should essentially see a genetics counselor, and then we should be guided by the various genetic abnormalities to know how to screen our patients. So this is quite intense already, but I think that the take-home message from this slide is that you need to risk stratify early, and then depending on your risk stratification, we're going to be modifying our actual screening protocol. So I just wanted to dive a little bit deeper into those patients with the greater than 20% risk, which we have established by our IBIS calculator. And here they're saying a clinical encounter every 6 to 12 months. And then they also say consider referral to a genetics counselor, to consider referral to a breast specialist. So they're not saying you have to do this, but consider it. Think about it, have it in the back of your head. And then they say their annual screening mammography with tomosynthesis, which would be fairly straightforward. And then what I think is so important that we often don't think about, because we sit in this idea of 40, previously 50, is to begin 10 years prior to the youngest family member that was diagnosed with breast cancer, but not prior to 30, because you're not going to get much information on a mammogram in that age group, or to begin at the age of 40, whichever
Britta?
comes first. Yes.
Sorry, I've got a question over here. You
Mhm.
mentioned that in a woman with very dense breast tissue, they should be screened more often. What's the best modality, particularly if they don't have a possibility of having annual MRIs? Any alternatives?
So I'm going to touch on that a little bit later. in
Okay,
the
okay, thanks
presentation.
very much.
But they are alternatives.
Okay, thank you.
Thankfully. And I think it's something that we need to really work at incorporating the alternatives, because I feel now that we have MRI available to us, the kind of knee-jerk responses, okay, let's get an MRI, and we definitely do not have buy-in from the medical aids.
Okay.
Okay, so I think at this point, I have absolute buy-in for MRI in my breast cancer patients for further workup, but for my patients with dense breast tissue, for screening purposes, no. But for my patients with a genetic abnormality, absolutely, they will get the annual screening MRI in addition to the 6-monthly alternating of a mammogram.
Okay.
Okay, does that sound right?
Thank you.
Cool. So then the next thing here, they say annual breast MRI with and without contrast. So this is where the cost and the time comes into play. So a breast MRI can take up to an hour if you're going to do a contrasted breast MRI. And this is not feasible for all our patients, especially if we're going to be using it for screening. So they actually do reduced study times and without contrast in the screening setting. So that wouldn't be appropriate in our breast cancer setting, but that is what they're doing overseas. Don't think we're there yet. It's something that we need a specific protocol for. I did just in the last week have a patient in renal failure that I needed to have an MRI for, and we did that uncontrasted. But as a result, the radiologist was very limited in what they could tell me. So that's why we want to reserve that for screening as opposed to diagnostic purposes in our breast cancer patients. Okay, then here they also say consider contrast enhanced mammography, an amazing modality. As far as I know, they have availability in Joburg. I think I remember Jenny Edge mentioning it. It's very, very commonly used in the UK, and it's a much more cost-effective modality than the MRI. And all it needs is an additional contrast injection at the time of the mammogram. You don't need newer, more special mammography equipment as far as I'm aware, but it is something that I would love to have available to us, especially for these patients where we're not going to get MRIs out of the medical aid. They mention here molecular breast imaging, not available in South Africa as far as I'm aware, so that falls in the realm of nuclear medicine. And then they also mention whole breast ultrasound. We routinely do whole breast ultrasound with our mammogram, so it is an excellent modality to use in addition to your screening mammogram for looking at those dense breasts. And this is put there as a recommendation only if the other imaging is not available. So I know in the States, they do also write in their reports that the patient will need an ultrasound or an MRI, and you kind of think, are they the same thing? No, they're not. But we'll look at what the false positive, false negative rates are there soon. And then again, they said begin 10 years prior to the youngest member. And very importantly here, which I think there's not enough focus on, and I was really forceful with, I think, in my morning meeting, was this: consider risk reduction strategies. And this is free. This does not cost money. And the main things that we can do to reduce patients' risk is to educate them about obesity and alcohol being major risk factors for breast cancer, as well as exogenous hormones. But at the end of the day, if you look at the Lancet Breast Cancer Commission, you can see that obesity and alcohol play a much bigger role than our exogenous hormones. So just something to consider. And then breast awareness again.
Britta?
Yes.
Sorry, what about smoking? Is that a risk factor?
So it's one that we allude to, but we haven't actually been able to pin it down as far as I'm aware. And in the Lancet Commission, they don't include smoking in the risk reduction as far as I'm aware. But I always encourage my patients, if they present with breast cancer and are smokers, to try and stop smoking, because it's going to affect their surgery and their radiation also. And my patients who don't have breast cancer but have dense breast tissue, or have a family history, or have had atypical ductal hyperplasia or ovular carcinoma in situ, I definitely encourage them to stop smoking. I think there's always a place to do that. Okay, so
Britta, can I just ask Britta?
yes.
They recommend stopping at about 73 or 75.
Mhm.
Do we actually do that here? Because I mean, some of our patients live quite long. What is the rationale behind that?
So that's also going to be covered a little bit later, but we should not be doing mammograms if the patient's life expectancy is less than 5 years, because the chances of us being able to be helpful in diagnosing a breast cancer early with a limited life expectancy is minimal. So as a rule, older patients get less aggressive breast cancers that ultimately will present clinically, and we don't need to screen for those necessarily. Does that make sense?
Yeah.
Okay, cool.
Okay.
So this summary I put in, but this looks just like a very long paragraph, so I'm going to skip over this one. So the NICE guidelines, so this is the UK, they send out invitations for routine mammography to women between the ages of 50 and 70 in England, North Ireland, Scotland, and Wales. And that invitation is sent out every 3rd year. They are the ones who conducted the study to see if extension to a younger and an older age would increase survival, and they concluded with that study that it did not, and that patients who had cancers in those age groups were more likely to present as not screen detected, rather be symptomatic. So they felt that the benefits did not outweigh the risk, if that makes sense. They do, however, have different guidelines for patients who have a strong family history or have genetic abnormalities. So theirs is also quite extensive. And I think here, what I just want you to note again is they aim to improve the long-term health of these families by describing strategies to reduce and to promote early breast cancer. So they're saying they want to reduce the risk again. So reducing the risk we spoke about just now, but they've added something to that, and that is tamoxifen. So I can clearly remember last year Davin sending me a screenshot of a report from the UK. This is the new answer. We're going to prevent breast cancer in thousands of women because we're going to put them on tamoxifen because they are higher risk. Those women are not going to be very happy with you for having been put on tamoxifen because of the side effects. And at the end of the day, yes, it will reduce your risk of breast cancer. And yes, we use it as part of our breast cancer treatment. But again, you need to weigh up the risks against the benefits. And I think most patients at the end of the day are not going to put up their hand for tamoxifen for risk reduction purposes. And even if it was thought to be a revelation, the pickup is going to be very, very poor. So the question of when should we stop? So this is based on the woman's overall health status. So yes, these guidelines have very cut and dry ages, but ultimately, if the life expectancy is less than 5 to 7 years, they are unlikely to benefit from it. So that's when we should stop. I find it very difficult to convince patients of this. I have patients that are older, that were Jenny's patients, that are beyond the point of being looked after by their oncologist, and they religiously want their annual mammogram. And I try and explain to them that I think you are of an age where we're not going to have a benefit, but generally speaking, they keep coming back. And I try and broach the subject annually. I think it's really difficult for patients to accept this, but I think it is something that we should think about when we are ordering screening mammography for our older patients. And yes, if your patient seems to be someone who's going to live to 100, by all means, continue. I don't have an issue with that. But if your patient is someone who is wheelchair bound with a carer during the day and a carer at night, there is absolutely no point in doing screening mammography for that patient because you're not going to increase her life expectancy. So this is a very nice table that is showing us all the different guidelines versus each other. So we've got there the American Radiology Society, we've got the American Cancer Society, we've got the American Obstetric and Gynecology Society. I think it's the American Medical Society, the American Breast Surgical Society, the NCCN is the known cancer type guidelines. And then the last one, I can't remember, unfortunately. But if you look at that, they're all saying they start at 40, except for the American Cancer Society. And then the stopping age, we're looking at life expectancy versus 75. And you can see here they've said life expectancy less than 10 years as opposed to the 5 that the earlier slide showed. And then the interval there overall is annual. Some of them are saying alternate years. and then with the American Cancer Society, depending on the age, what their recommendations are. So I think the take-home message here is it's variable. You can't be told that you're doing the wrong thing if you are following one guideline and a different guideline has different recommendations. I think just choose to be consistent in what you do, and that will be fine. So now to focus on dense breast tissue. So this is a great illustration of what we're talking about. So on the left, we have an illustration of what the components are of the breast, and you can see there the pectoral muscle, you can see the lymph nodes in the axillary tail of the breast. Often you see those lymph nodes over the pectoral muscle too. And then they're showing us the glands and the ducts and the fatty tissue. And on the right, you see the solid white in the middle of the breast, and then you see the little white round beans at the top, and you see the solid white again, which is the muscle. So you can see what the appearance would be of the various structures schematically on your mammogram. So you can clearly see those lymph nodes. You can't very clearly distinguish anything in the white area, but you can clearly see through the black area, which is the fat. And this is how mammography is. So, density of the breast is put into one of these 4 categories. So when you see your mammogram report, if you guys actually look at the images, I always look at the images myself before reading the report, but I obviously don't expect you guys to do that. But it's nice to sometimes just glance and see what are they actually talking about. So when they are saying that this is breast density A, they're talking about the beautiful fatty breast with hardly any glandular tissue. In this fatty breast, you can clearly see the small cancer anteriorly. Next, we have breast density B. So here we have scattered glandular tissue, and already in this, you're starting to have some difficulty finding that cancer. Although it's brighter than the glandular tissue, it's blending in quite well. And now we head towards the dense breast tissue, where we have the heterogeneously dense versus the extremely dense. And you can see there is very little fatty tissue. There is a lot of glandular tissue, and that breast cancer is almost invisible. And in the extremely dense breast with the D, that breast cancer is gone. So this is why we need something in addition to the mammogram to be able to find the cancer if we're going to be looking for a small cancer in the screening setting. So I also like to explain to my patients that the mammogram is my roadmap. If I see something abnormal on the mammogram, I'm going to look harder with my second modality in that area. And if I'm presented with breast density D, I'm not going to go looking for that small cancer. I might be lucky if I find it with the ultrasound because there isn't a roadmap for me. So you understand why these patients are at a higher risk. Okay. So just descriptively, we have the A, which is almost entirely fatty, and only about 10% of women will have these beautiful fatty breasts. And then we have the scattered fibroglandular tissue, which is about 40%. So now we're saying 50% of our women are going to have dense breast. That's going to need supplemental imaging with an MRI. There is absolutely no way that we're going to get funding for that. So thankfully, the extremely dense is only another 10%, whereas the heterogeneously dense is about 40%. So what is our cancer detection rate? When we have 1,000 women having 2D screening, and 2D screening is not our standard at this point. Maybe elsewhere in the country, it depends on what you have available to you. I know we do have some of the hospitals that are still doing 2D, but our main standard now is tomosynthesis, and tomosynthesis already is more accurate at detecting small cancers than 2D. So if we have 100 out of 100, 100 out of the 1,000 will have the recommendation to come back for more testing. And out of those, 95 will likely have a false positive, and only about 2 to 7 breast cancers will be found per 1,000 women that we screen. And this is a lovely illustration of how many more cancers we're going to be picking up, depending on which additional imaging modality we use. So there you can see the 2D versus the 3D, so the standard older form of mammography versus the tomosynthesis, then mammography with an ultrasound, mammography with molecular breast imaging, so that was the nuclear medicine, mammography with contrast enhancement, that's the one that I'd really like to have access to, and then mammography with an MRI, which ultimately is going to get the best pickup. But I think that contrast enhanced mammography is a very close second to the MRI. So this is just a tabulated form of what that graph showed you, and then basically giving us an indication of what the false positive rate is going to be depending on the imaging modality, and also commenting on availability. So here you can see that the contrast enhanced mammography and the molecular breast imaging is also limited where these guidelines are from. So nice flow chart again, slightly simpler than the one I showed earlier, and very similar principles, but this is now looking more at breast density than the overall picture. And there you see the risk assessment by age 25, and they're saying about the genetic variations, the increased risk of greater than 20%, previous chest wall radiation, and then they have the dense breasts, or I'll have to look up the PHBC. Sorry, I think that will be on my next page. And then they say, if you have any of that, then you start your screening at an earlier age. But if you don't, then we're going to start at 40. And then you can see there the mammography versus other techniques. And then ultimately they say stop screening when life expectancy is less than 10 years. Just see that footnote. Oh, they said personal history of breast cancer. So that was up there where it said personal history of breast cancer and dense breast tissue. So I don't think those patients should be in this flow chart. I must say, I disagree with them adding that here, but anyway, that's my opinion. So I invite you guys to have a look at this website. It is absolutely fascinating to me. I had never seen it before. I'd had presentations with this information that I'd heard given by radiologists, but I'd never actually accessed the information myself. And every question you have about dense breasts is answered there. There's a whole list of questions. There's videos. I mean, I could have just put all their videos back to back and you probably would have learned more than what I have to say, but it's brilliant. So go check it out. And then I'm moving on to just 2 case studies. And these are 2 of my patients from this year. So the first patient is 54. This was her first mammogram. She had a very young age of menarche, 8, with early menopause, 1 child with no breastfeeding, and she had quite a significant family history of cancer: breast cancer, prostate cancer, lymphoma, and gastric cancer. And you can see here, she has beautiful fatty breasts. But you can see these white flecks in the upper aspect of this breast, spread quite widely. And this is her breast in the CC view, and this is the breast in the MRL view. And here you can see those lymph nodes that I demonstrated for you earlier up at the axillary tail. And you shouldn't really comment on those lymph nodes in the mammogram, but those look abnormal to me already. And you can see here that the mammogram report said she had breast density A, and they reported multiple areas of clustered pleomorphic calcifications. They didn't see a mass. They noted that the lymph node was prominent, and then went on to have an ultrasound. I'll share that image soon. And they didn't find anything on the left-hand side, and they've given her a BI-RADS 5. And this is the image of her lymph node. And you can clearly see there's cortical thickening of that lymph node, although the fatty hilum is not replaced. So this patient went on to have a biopsy of the breast. The breast showed that she had DCIS. The lymph node showed that she had metastatic disease. DCIS is not meant to metastasize, so ultimately we were suspicious of very small invasive component. So she did go on to have an MRI and surgery. And the question I have for you is, do you think she started her screening at the appropriate age? And do you think there's anything that we could have done to reduce her risk?
Well, Britta, this begs the question. We should have started screening it in the 40s.
Agreed. Yeah. Definitely. And anything else that you would have done for her differently?
I don't know.
Would you have sent her to a genetics counselor?
Yes,
Or
of course. If you've got a paternal
inputted
cousin
her
breast.
into your IBIS risk calculator?
Yeah, paternal family prostate cancer, including the father, maternal family lymphoma, uncle stomach cancer, cousin breast cancer. All of those should prompt a visit to your geneticist.
Definitely. So I think that's something that would have been good to consider early. I did include that in her breast cancer journey, obviously, but I think it's just useful to look at this case and be like, what could we have done better, considering the guidelines that we have?
Also, she's got the high risk factors of no breastfeeding and only one child.
Yes.
And menarche at 8.
Yes.
Yeah.
And I haven't included her BMI, but she had a very raised BMI. So that was also something that was modifiable early. Okay.
Right.
And I have one more case. So this is a young woman who I met 2 months ago, whose gynae was very astute and took the family history very seriously. And this woman presented to her gynae, had her first mammogram at the age of 33. Menarche was 14. She's been on Depo-Provera since the age of 28, so that's 5 years. And her mother was diagnosed with breast cancer at 38. So her gynecologist very appropriately referred her for her first mammogram. And I've put the ultrasound here first so that you can see how small this cancer is. 6 millimeters. And this is her mammogram. And the reason I put the ultrasound first is because I often get called where the patient does not want to have radiation from a mammogram. Is it okay if we just do an ultrasound? The only reason they found the 6 millimeter tumor on her ultrasound was because they had the roadmap of the mammogram, in my opinion. If you just did a routine ultrasound looking at the breast, you wouldn't necessarily have found this. So if you look at her mammogram, she's got breast density B, but you can clearly see a spiculated lesion on her tomosynthesis on more than one slice. May not have seen that on a conventional mammogram, but on the tomosynthesis, it was pretty obvious. And on the ultrasound, they could identify it and then proceed to a biopsy. Anything that you would have done differently for this patient?
I don't think the Depo makes any alterations to her stratification of positivity.
Agree.
Do you think so?
No, I think it's fine. I don't know.
And someone said, what about another person says, what about on the subject of Depo, what about progesterones as in Mirena? Does that predispose? Is that a risk factor or not?
So there's a lot of talk at this point on the combined oral contraceptive. Mirena, we used to be okay with in our breast cancer patients, but now we're not okay with it. So the straightforward answer from me is I'm not 100% sure, but I personally don't think that having this patient in front of me at this age, that her contraceptive choice was incorrect. And if she'd been on a Mirena, I would have been fine with that too. But going forward, now with the breast cancer diagnosis, we would definitely change that to a copper T if she still wanted a intrauterine contraceptive device.
Right.
Cool. So that brings me to the end of my presentation.
Fantastic, Britta. We've got a whole list of questions. We're going to start there. Anonymous,
okay.
Is there any evidence for ultrasound screening only over, I think you've mentioned this, over mammography? I assume not. However, I've heard a lot of women asking about it as it's an alternative to getting uncomfortable mammograms. So you said no.
So if your patient is not willing to have anything except an ultrasound, it's better than nothing.
Yeah.
So go for it.
Okay, thank you.
I often have patients that like say the radiation thing or the uncomfort. I have small breasts personally. The most uncomfortable part of mammography is that I need to turn my neck out of the way so that they can see enough of my boob. And my instant thought process was like, how do my elderly patients handle this? But luckily their breasts are more ptotic. And tomosynthesis is not a painful process. It's
Okay.
a bit uncomfortable, but it is not a painful process because with tomosynthesis, we do not need to press as hard as we did with conventional mammography because it's like a 3D image. So multiple slices as opposed to squash, squash, one shot, one shot.
So we don't do squash, one shot anymore? Is that digital mammography is better than that?
Definitely.
Okay. Graham Birdsey, can you comment on breast thermography? I have patients, says Graham, I have patients telling me that that's how they're doing their screening. Is this kosher or is this snake oil?
Snake oil, unfortunately.
Okay.
In the recommendations, it will recommend against it. It's not part of the screening protocols. As an aside, I have had patients that have used that, and interestingly, one actually got told by the person who did the thermal scan to please go and have a proper mammogram and ultrasound.
Okay. Another anonymous, evening. What is the risk of the radiation? What is the risk for radiation from annual mammography to the patients? Is this the same as flying to Joburg or to London, or is this less or more?
I would say it's less.
Less,
Less than flying, definitely. I also clearly remember Jenny always saying that the radiation we're getting from the granite from our Table Mountain is far greater than our patients will ever experience from their mammograms.
Okay, so that's not significant, Graham. Yeah, then just a quick one over here. You didn't mention self-examination of the breast. Is this a proper screening or is this just a very good thing to do and a very good habit to practice? Self-examination of the breasts.
So I think self-examination is excellent. I think in the right patient. It stresses a lot of women out, especially where they have very glandular breasts or cystic breasts, they like to say, because they can feel all sorts of lumps and bumps. So what I like to educate my patients on is the inspection model. I have no issue with them feeling their breasts, but often they don't feel their breasts in the correct way. So if they've been taught properly how to do it, it's a great modality. And where we do not have mammography available to us, clinical examination for screening purposes, essential and excellent.
Rupert Moodley says that last patient, BRCA screened to the last patient, ? So that would be yes.
Absolutely. She did have genetic testing, and her genetic testing for the 84 gene and Vitae panel came back as completely negative. But it's most appropriate to do genetic screening for her. Yes.
Anonymous says, what constitutes previous chest radiation? Does that include a basic chest X-ray and chest CT scan? Does that constitute it?
No, we're talking about chest wall radiation for patients, often like the Wilms tumors in pediatrics, or chest wall radiation for lymphoma. So like in the treatment setting, not the diagnostic
More
setting.
therapeutic than diagnostic. Anonymous says, talking about lights and thermography, what are your thoughts on breast light examination being offered at some pharmacies as a thermography? Patients think they've had a screening. Is this again kosher or is it more snake oil? Breast light examination.
I have not heard of it, but
It's where they shine a strong light through your breast, and they say, "Oh, this is a way of screening for breast cancer." You've not heard of that? Okay, well, that answers that question.
I hope they
Steve.
don't get sunburnt in the process.
Okay. Steve, are you still with us? Steve.
Absolutely, yeah. Peter, you've missed this question from Kathy van der Westhuizen.
Right. Now, I'll tell you why I went back to it, Steve. It's just that we had all these other little questions, which are all excellent questions, but I thank the people for asking. Okay, Steve, you asked that question from Kathy van der Westhuizen.
Quite a long question. I just
Well, that's why I kept it for the end.
Okay. So I just met a 33-year-old patient with a very strong family history of breast cancer. Mom died last year of triple negative breast cancer, which developed some 8 years after initial breast initial breast cancer, the contralateral breast, and then BRCA1 mutation positive. 3 maternal first cousins, 2 while in their 30s have also had breast cancer, all confirmed BRCA1 positive, but she declined genetic testing at this stage. Can she have a mammogram now? And will Discovery pay for this from a screening benefit? Or should she have an MRI? So there's a 33-year-old patient, very strong family history, but declining genetic testing. What are your thoughts, Britta?
First thought, she needs a psychologist. She obviously has something that we need to dig deeper into, because if she has genetic testing and she's BRCA negative, then she's going to have a huge cloud taken away. And if she's BRCA positive, her medical aid is going to fund everything that she needs. So that's the communication and understanding is where I would start. And I definitely think she will be able to have a mammogram, especially with the family history of breast cancer in the 30s. When you said triple negative, my instant thought was BRCA, and that was confirmed with that genetic testing. I had a patient just a month ago whose sister was my first patient, but came just for a routine breast examination because she had tested positive for a CHEK2 mutation. And she had gone for genetic testing because her sister had developed breast cancer in the UK and was CHEK2 mutation positive. And the third sister decided not to test. And the third sister presented to me a month ago with bilateral breast cancer.
Okay.
And
so the
she
bottom line is
had
this:
her testing last year when her older sister tested and known her genetic risk and started her screening, and perhaps have had prophylactic surgery before developing breast cancer.
So she signed her own death warrant. So it's a case of you can't have your cake and eat it. If you're going to decline genetic testing, as in Kathy van der Westhuizen's case, you're cutting off your nose to spite your face. Is that what you're saying, Britta?
Absolutely.
Okay. Well, Steve, I'm going to ask you to thank Britta. Britta. But just before you do that, just to remind everybody over here that next week on the same platform, we have Professor Lo Pistorius, and he's talking about NIPT and new NT scans. And that's sponsored by Next Biosciences. He, like Britta Dedekind, is a very popular speaker. We've had over 100 people here this afternoon. And Lo Pistorius is also well worth listening to. And he's talking about NIPT and nuchal translucency scans. So we'll see you then. Steve, would you like to thank Britta?
Oh, absolutely. I mean, it's been wonderful, Britta. I mean, you really brought some clarity to the complexities and also shown us some of the finer nuances of how to choose. And I mean, it appears that you really need to take a good history and really tailor your screening to the patient. It's not just a matter of, throwing a protocol at the patient. So thanks so much. And I think we're going to be a little bit more astute in terms of how we look at our patients and how we recommend screening. So thanks so much. And we really appreciate it. Good luck. Britta's actually given a talk this morning already on Chris Barnard, and she's got more talks tomorrow. So she's having a really busy time. But thanks very much for taking time to give this talk tonight. And I think you really made a big difference to the way we can approach this problem. So thanks so much.
Absolute pleasure. Thank you for having me.
And also thanks to Merck for sponsoring this session. It's been wonderful. And God willing, we see you all over here on the same platform next week. Thanks so much, Britta, and safe home.
Thank you very much.
Okay.
Goodbye.
Bye.